This chapter talks about collaboration and with practice and care coordination across the settings. The role of the nurse in community-based care is to provide continuity of care when a patient moves from one level of care to another or from one setting to another. So the nurse's role is to be that intermediary to make sure that the patient's care is being coordinated and that those that are involved with the care are able to provide interventions that will work the best for them. Also, so that they can manage acute or chronic illnesses. So somebody may have a chronic illness and they develop an acute exacerbation of their chronic illness, or they develop another illness that affects their chronic condition and may have to be admitted to a hospital from a community environment. So this home health nurse has been helping the patient with their chronic care, may give report to the acute care nurse in the hospital so that that acute care nurse has more ideas of what works for the patient or what doesn't work for the patient. Also, within community-based care, it's important for the nurse to promote self-care for the clients so that they're able to do more for themselves. We know that patients do better when they are more participatory in their own care. Some of the types of home care agencies that we have may be official or public agencies or voluntary or not-for-profit agencies like March of Dimes or the American Heart Association. The private proprietary agencies are going to be more of the home health care agencies themselves, that this is their business to provide this home health care. And then we have institutional-based agencies. So there may be a hospital who also has a home health care or a hospital that has outpatient services that meet some of the home health care needs of their clients. Some of the qualities of a community-based nurse is that they're knowledgeable and skilled and to understand the care required of a variety of disease states. They have to be independent in making decisions, because if they are not independent, if they're having to call the doctor every time something comes up with one of their patients, that doctor's going to be really tired of getting phone calls from them very quickly. They also have to be accountable. So you can't send somebody out into somebody's private home if you're worried about whether they're going to steal from them or whether or not they're really going to show up at that person's house or not, or whether they're going to spend too much time there and bill for more hours than what really needs to be billed for. The roles of the community health based nurse is, number one, is a patient advocate. And often people feel as though they don't have a voice. And so the home health nurse works to be that voice for that patient that may not feel that they are able to address things with their provider themselves. They're also a coordinator of service, and I've mentioned this to a few of you, that the home health nurse will often be the one to make sure that the other allied health providers are meeting the needs of that client. So if the doctor, who is one of our partners, our team members, writes an order for physical therapy, I'm going to ask my client, if they've talked with the physical therapy group yet, and if they haven't heard back from them or the physical therapy people haven't called them, as the coordinator of service, I'm going to call the providers and say, hey, we have an order from Dr. Smith and just wondered when you all are planning on coming out and doing your initial assessment. I work with Mr. Jones and I want to make sure that he's available and he's going to be at his best when you come here. And so you start coordinating that care. On the other hand, you might have a situation where he's running out of his medication and it's due to be refilled and there's no renewal on it. And so you're going to call up the doctor and you're going to say, Dr. Smith, Mr. Jones is starting to run out of his medication and I notice there's no refills on it. Do you want to renew this medication? And most likely he probably is going to do that and he's going to call in the prescription. On the other hand, he might say, no, I really want to see him before I renew it. When can we get him in? And you as the coordinator of care might set up the appointment or help the client to set up the appointment and maybe even arrange for transportation to get the patient to the doctor's office for their appointment. Also, you are the patient and family educator. There's a lot of, when people have chronic disorders, there are a lot of things that need to be educated with. And so it's important to have somebody who is knowledgeable and can help that client figure out and understand what's happening to him and why certain treatments need to be given. Sometimes they'll say, I don't know why I have to do this physical therapy. I'm just fine. I walk around the house or walk around the yard just fine. Yeah, it hurts a little bit when I do this, but I'm just fine. And so as the educator, we help the family and the patient understand why treatments are ordered for them and also how their disease works. We look back at that health literacy and helping them to be more literate in their health care. Some of the 4 concepts that are essential to nursing care of patients across settings is that in community-based nursing care, it's more than just the nurse doing all of the care. She has to work with other members of the healthcare team. She makes sure that there is continuity of care as this patient needs to move from spot to spot. There is collaborative practice when we're looking at continuity of care. So I may be working with a physical therapist, I may be working with a respiratory therapist. I'm working closely with the physician that is caring for this patient. And I'm working in the care coordination. The continuity care is a process by which healthcare providers give appropriate, uninterrupted care and facilitate the patient's transition between different settings and levels of care. If I'm caring for this patient at home and I start seeing that he's not doing well, he's not his usual self, that patient may be sitting there going, no, I don't need to go to the hospital. But I know as the professional that they need more care. And so I help to ensure there's a smooth transition between ambulatory care to acute care and back to home health care if they need more follow-up after their discharge. And that I also make sure there's a smooth transition for any other types of healthcare settings that they need, whether they're going to a clinic or an outpatient therapy center. The continuity of care depends on excellent communication as they move from one caregiver or a healthcare site to another. So we share information about that client so that the care can be efficient and it can be appropriate for that patient. We have the ISBRQ method of patient handoff, which the I is the introduction. And we say, hello, Dr. Smith. I am Faye Foreman, and I am taking care of your patient, Mr. Jones. And then I give him the situation. Today, as I came to visit him, I noticed that he's not as alert as what I am used to seeing him be. And previously, he was able to converse with me freely without any difficulty. Today, he seems to have a hard time expressing himself. On my assessment, I noticed that his blood pressure is elevated and his temperature is slightly increased. I was wondering, and here we are to the recommendation, whether we might, and whether you'd like to have some lab work drawn on him. I'm worried that he might be coming down with some type of an infection, and that's what is affecting his cognitive ability. And so then the doctor might say, well, I just saw him yesterday and he seemed fine yesterday. This is what I saw. And you would say, well, this is what I'm seeing today. And the doctor might say, well, definitely that's a change from when I saw him last time. Yes, I think that's a great recommendation. Let me call into the hospital for him to get lab work done. Can you get him there? And so then we're going to work out those alternatives, and ultimately we're going to say something like, do you have any further questions? And I'm going to say, well, I was worried about something else, and I may talk to them about something else. This ISBRQ also works when we're doing handoff from one nurse to another. So when I'm the home health nurse and I'm talking to the acute care nurse, I might say, hi, I'm Faye Foreman. I am the home health care nurse caring for Mr. Jones. We're bringing him in today because I'm seeing decreased cognitive ability. His blood pressure is elevated. His temperature is elevated. We have a concern that he may be developing an infection. And previously he was alert and oriented ×4, and I've not seen him this way except when he becomes ill. And I've talked with Dr. Jones or Dr. Smith, and Dr. Smith has said that he wants blood work done, and afterwards he would like to have him started on antibiotics. And I'm sure that you've received orders from him for his admission. Are there any questions that I can answer about Mr. Jones? Because I have taken care of him for a long period of time. And so the nurse might ask, what is he normally like? Has he ever had any problems with falls? Has he ever had a stroke? So there may be numerous things that they ask during this question and answer period. The goal of collaborative practice is to deliberately work together to build a safer and better patient-centered and community or population-oriented U.S. healthcare system. And it happens when multiple health workers from different professions and backgrounds work together with their patients, the family, the caregivers, and the communities to deliver high-quality care. So as you know, these healthcare workers can be anyone from the janitors that are caring for the environment to the respiratory therapists, the dietitian, the nurses, the physical therapists, occupational therapists, and the physicians, nurse practitioners, or physician's assistants. An effective team interacts interdependently and adaptively. So like I said, this community health nurse maybe making sure that the physical therapist comes, that the physical therapist may make recommendations for follow-up exercises to take place on the opposite days of when the physical therapist comes and works with the patient. And so as the nurse, I may assist the patient in doing those exercises. And we have complementary skills. It's not that one person has better skills than another person has, but that these skills work together to provide the best care for that patient. It should have effective leadership. And that leadership may not be the physician, although the physician is going to be evaluating and writing orders and things like that for the patient, but it may be the nurse that is helping to lead that team structure because she sees that patient more often. A team needs to be working for a common goal. It doesn't do any good if the doctor's goal for that patient is that they're just going to survive for another 6 months. And my goal for the patient is that they're going to lead the most productive life that they can over that 6-month period of time. Or that their goal is different than what the patient's goal is, where the patient may say, I just want to be comfortable. I know I only have 6 months to live. I just want to be comfortable in my home. We need to have clear roles and responsibilities so that nobody's feet are getting stepped on. And each person within the team needs to hold themselves mutually accountable for achieving the goal that is set between the team and the patient. Some of the competencies that are needed for interprofessional practice is that they work with people of other professions to maintain a climate of mutual respect and shared values. We use the knowledge of your own role and those of other professions to appropriately assess and address the healthcare needs of patients in a population served. I have to admit that sometimes we focus in so much on our own profession that we really don't know what the other professionals can do or can't do. And it was interesting because last semester, one of my assignments was to look at the practice acts for physical therapists, occupational therapists, and for athletic trainers. And then I had to do a project and write a paper about that information that I had obtained in relationship to a case study. I was really kind of surprised to find out how broad many of the practice acts are for these different allied health professions, and how that interplays with the nursing scope of practice. We want to make sure that we communicate with patients, families, and communities and other health professionals in a responsive and responsible manner that supports a team approach to the maintenance of health and treatment of disease. We've talked a little bit about conflict within healthcare. If I am implying to a patient or their family or a community that one person's skills are not adequate and only mine are, then I am not being responsive or responsible to that community or that patient that I'm caring for. We want to apply relationship building values and principles of team dynamics to perform effectively in different team roles, to plan and deliver patient-centered or population-centered care that's safe, timely, efficient, effective, and equitable. I'm not going to treat one group of people better than I treat another group of people, and I'm going to make sure my team members don't do that either. When we look at care coordination, We want to make sure that the care transition is a continuous process in which the patient's care shifts from being provided in one setting to another. And that central responsibility for all healthcare professionals, and especially nurses, are taken care of within that care coordination. The aim is to link patients with resources in the community that will enhance their well-being, improve the information exchange that is necessary for them to be as healthy as they can be, and reduce fragmentation and duplication of services. I don't know if very many of you have ever had to deal with some of these things, but when you start taking courses or doing things, and it's like, well, I do that with this person over here. Why are you doing the same thing with me? Here within the nursing department, we often will try to coordinate our classes so that you're learning similar things approximately the same time, so that it reinforces it. We don't view it as a duplication of services, but more of a reinforcement of information. And so sometimes that's important, and there's a difference between duplication and reinforcement. But that's very important in our care coordination. If the patient was seeing an occupational therapist and they were seeing a physical therapist, and both of them were working on the same type of mobility problems, that's when we would see a duplication of service that really was not benefiting the patient. We have your book had what they called the care coordination ring. And when we look at that, we ultimately need to meet the patient needs and preferences in delivery of high quality and high value care. And we do that through the patient and family perspective. We're going to ask them what they consider to be high quality and high value care. And then we have to look at how that compares to what the healthcare professional's perspective of that is, and also the system representative perspective, which may be a hospital system or maybe the insurance for that patient. And the people that are involved in that are going to be the patient and family education and support, the medications or the pharmacy, meeting the needs of getting them their medications, providing community resources that are what they need, looking at their primary care, which is usually when we're looking at physicians. If they need specialty care, how much specialty care do they need? Is one meeting the needs and that's all they need? But they may need a second specialty care to provide for other needs. We look at their inpatient care. Hopefully they're not having inpatient care, but they may need inpatient care. We look at mental health services in some cases for some of our patients. Do they need long-term care? What does their medical history tell us about their needs? What are their test results showing? What is their home care? What are they getting now? Could we provide better home care for them? And who are their informal caregivers? We think of the nurse and other therapists as being their formal caregivers, but what about the informal caregivers? The daughters, the sons, the grandchildren, even in some cases. We're starting to see a new role coming up in nursing, and that's the role of the patient navigator. And the patient navigator assists with scheduling, financial assistance, psychosocial support, and community support. So you can see how the home health nurse may be involved as a navigator, but the navigator takes care of things that are really may not be so much nursing related, because if we look at scheduling and financial assistance and community support, that may not be so much a nursing aspect. We have to worry about vulnerable populations in all of these situations. So people that we consider to be vulnerable are people with disabilities or multiple chronic conditions, people with mental illness or substance abuse, people of cultural, racial, or ethnic minorities, the rural and urban poor. There's a difference between a poor person in a rural area and a poor person in an urban environment. One may be able to deal with providing because they're able to plant, and so at least some of the year they're able to provide for some of their needs, where in an urban environment, that may not be an option for them. We look at poverty and homelessness in both cases. Probably homelessness hits much harder in the rural areas because there's less support systems available for people that are homeless in a rural environment. And then we look at undocumented immigrants as another vulnerable population, and you know how controversial that subject is right now as far as how much do we provide for undocumented immigrants. But as caregivers, what is our role in the care of that vulnerable population? It's important for us to establish effective nurse-patient relationships, no matter who you are and whether you're a part of a vulnerable population or a not so vulnerable population. We do this by reducing anxiety through therapeutic communication, teaching and acceptance of that person. And that's some of the things that we've been spending a lot of time talking about over the last week or two, about really learning to hone in on your therapeutic communication. Remember that the patient has concerns and needs that are way beyond the medical ones that you may see as highest priority. Think about that Maslow's hierarchy of needs, that if your physical needs are not being met, you're not going to really be so worried about some of your safety needs. But yet, we also know about Maslow's hierarchy is that although there is a hierarchy to those needs, it doesn't mean that you don't worry about those things, that you don't worry about your love and acceptance needs, even though your safety or physical needs are not being met. In fact, the fact that those needs are not being met may make you worry more about your relationships and whether there's more stress involved with them. We want to communicate with the patient as an individual. We aren't saying that because you're an undocumented worker that you have the same problems as all other undocumented workers and I'm going to treat you as such. You have to approach this person as an individual. You're going to take time to learn about the patient that's being admitted to your care. How else are you going to have a relationship with them if you're not learning what's important to that person? And you're going to provide for family participation in all aspects of care. Obviously, when we say all, we're not talking every single one because it may not be appropriate in some cases, but we want the family to participate in the care of the patient. When we're admitting to an ambulatory care setting, the patient receives health care services, but they don't remain overnight. And in most offices and clinics, patients complete a short health history as part of the admission to that ambulatory care setting. In same-day surgery facilities, There may be screening tests, teaching, and other things like that that happen as part of the admission before the patients enter the setting. When we admit to the hospital, the admission sheet becomes part of the medical record. And I think it's kind of interesting that your book is still using the phrase the admission sheet, because what actually happens is we go into a computer and we start asking questions of the patient that in previous years would have been on an admission sheet that we were filling out as we ask the patient these questions. A bracelet is placed on the wrist of the patient that has their name and their birth date and their identification number. And in some cases, it may have a number that indicates what how many times they've been in that hospital in the past. A nursing interview and physical assessment are conducted as part of this admission process, and a room is prepared for the patient. Sometimes that room is prepared before they actually get up there, and so some of these activities take place in the room that's been prepared for them. Some of the information that's obtained on the admission sheet includes, or the admission form on the computer includes the name, address, and date of birth of the patient, their gender, and their marital status, the name of the admitting physician, the name of their nearest relative, their occupation and their employer's name, the financial status for healthcare payment. Are they paying cash? Do they have insurance? Do they have Medicaid, Medi-Cal, something, or Medicare that's providing? What is their religious preference? What is the date and the time of their admission? And what is their admitting diagnosis, as well as the identification number for that patient? When we prepare a room for a patient, we position and open up the bed. So we don't keep the bed made for them because we want it to be inviting for them to get into the bed. We assemble whatever necessary equipment and supplies are going to be necessary in admitting the patients, and assemble special equipment and supplies as well. It depends on the type of patient, what type of equipment may be necessary, but in most hospitals we have suction that's already been set up at the bedside so that if a patient suddenly needs to have suctioning, all we have to do is turn it on and we're able to use it. For some patients, we may have a bag and mask and oxygen available for them as well. We're going to adjust the physical environment of the room, making sure that the room is at a comfortable temperature, that there's nothing in the room for people to trip over, or that the chairs aren't in the way as they bring the patient on a gurney or in a wheelchair. Going back to that special equipment, if I'm admitting somebody to an ICU, I'm also going to have their monitors set up so that with all of the leads, the pulse oximeters, whatever else they may possibly already have, already set up and ready to connect. If I already know what their IV fluids are going to be, I'm going to have their IV fluids there with a kit, IV start kit, so that I can start their IV for them. All of these things are going to be there and ready so that when the patient comes in the room, we're able to seamlessly admit them to that room, and that we're not having to go in and out and in and out and in and out because we don't have everything that we need. When we do transfers within the hospital setting, we move the patient's personal belongings to a new room. And we transfer the patient's chart. If they have a Cardex, we take that with us. The care plan and any medications goes with that patient. We notify the other hospital departments of the move so that they don't come looking for that patient and he's not there anymore. And we give verbal report to the nurse in the new area. In some cases, we may actually go with the patient and give report at the bedside about the patient. In other cases, depending on the acuity or the condition of the patient, we may just call by telephone and give a report by telephone. But we really are kind of moving away from that and giving verbal report at the bedside. Information that's included in the verbal report includes the patient's name and age, the physician, and the admitting diagnosis. If there's a surgical procedure, we're going to let them know about a surgical procedure if it is to be done or if it has already been done. What their current condition is and any manifestations of that. So if I have a patient who's had surgery, I might say he had an appendectomy yesterday that found a ruptured appendix. The patient is on antibiotics due to the ruptured appendix and is having a fair amount of pain. I last gave their pain medication at 9 o'clock this morning, and for a pain level of 8 out of 10. After giving the medication, the pain level came down to a 3. And so that the person who's getting them knows what's been going on with this patient. We're also going to tell them about any allergies, medications that they're on, or treatments that they're receiving. We're going to let them know about any necessary laboratory data or any special equipment. So on our patient with an appendectomy, I'm going to say his appendectomy was yesterday and his white count this morning was this, because his white blood count is going to tell me about the infectious process, and that's what I'm concerned about with him. His segs and bands were this, which is another way that we look at infection. And his blood cultures have been negative to date. He will have more labs have been ordered for tomorrow morning, and so that nurse knows what to expect. We're going to give nursing care priorities. So I've already told her that pain is a major issue for him as well as infection. So knowing that infection and pain are an issue, I'm going to be watching for his infection getting worse or better, but worse is always what we end up thinking about, the bad side of things, or if the pain medication is not taking care of his pain. And then an existence of any advance directives, especially if the patient is going into an ICU situation where their condition has worsened and they could possibly die. We want to know if there's any advance directives. But even if not, we want to know about advance directives. When transferring a patient to a long-term facility, we send a copy of the medical record with the patient. The original record is the legal document that stays within that hospital where the patient came from. But we do send a copy with the patient so that the people that are taking over care of that patient can look back and see what has happened during the admission to the acute care hospital. We're going to send a detailed assessment and care plan with the patient as well. The patient's belongings, prescription, and appointment cards are also sent to the facility with the patient. We don't hang on to their stuff. But we don't send extras. So if in the drawer we have unopened medications because it's unit-based dose medications, I'm not going to send an extra dose of his meds to go with him. That's the responsibility of the long-term care facility. And the nurse often provides a verbal report to the new nurse. In this case, where we're transferring them to another facility, that report is often given verbally over the phone. Some of the essential components of discharge planning include assessing strengths and limitations of the patient, the family, or the support person, and assessing the environment that they are going to be discharged to. Also, to implement and coordinate a care plan for after discharge. We also want to consider the individual, the family, and the community resources that are available and how that would relate to their care. And then we're going to evaluate the effectiveness of care with the after discharge. The criteria for formal discharge planning and referrals is that there may be a lack of knowledge about the treatment plan. So we're going to do discharge teaching with the patient to make sure that they understand what the treatment plan is. Social isolation can affect whether or not somebody follows up on plans and referrals that have been made. And if there is social isolation, referral for a home health care nurse to come in and to help the patient with their treatment plan is usually something that we want to do as part of their follow-up. If they've recently been diagnosed with a chronic disease, they are going to need referrals to help them deal with the changes that are associated with that disease state. If they've had major surgery, they're definitely going to have a discharge plan that includes referrals for follow-up. As well as if somebody has prolonged recuperation after a major surgery, then we're probably going to be bringing in a home health nurse or referring for other treatment as needed. If there's emotional or mental instability, we may have a psychiatric home health nurse going out and visiting, or we may refer them to a support group for treatment. If there's a complex home health care regimen, we are going to be looking at referrals possibly for respite care for the family, which would mean that if the care of that family member is so intense that you don't ever get to take care of yourself, you need respite care so that you can actually take care of your own needs. If there's financial difficulties, we're going to refer them to organizations that can help them with those financial difficulties in paying for their medical care. If there's a lack of available or appropriate referral sources, it makes the formal discharge plan much more difficult. Or if there's terminal illness, we may be referring them to hospice. Some of the guidelines for discharging planning including assessing and identifying. So if you think about putting this in the design of the nursing process, we're going to assess and identify. We always start the nursing process with that. So we're going to assess and identify healthcare needs of this person as they're going home. We're going to set goals with the patient. So this assessing and identifying, assess, diagnose. So the diagnosis is part of the identifying. Setting goals is part of your planning stage. Teaching the family, implementation. Providing home health care referrals, interventions. And then evaluate the discharge planning effectiveness. Now we're in the evaluation stage of the nursing process. Every once in a while, we've got that patient that decides they don't want to be there anymore. Maybe there's been a nurse in there that has upset them, or the doctor doesn't seem to be hearing them, but they've become upset and they've decided they're going to leave. A patient is always legally free to leave a hospital. But we have to make sure that they understand that that choice carries a risk for increased illness or complications from an illness or surgery that they've had. The patient must sign a release form understanding that states that they understand that they are leaving against medical advice. The patient is informed of their risks that could happen before they sign that form, and the patient's signature must be witnessed. And in some cases, it needs to be witnessed by two people. The form becomes part of the medical record so that if something happens to that patient, especially soon after discharge, the organization can come back and say he was warned of the risks that could happen and he chose to leave against medical advice. And then the organization is not held liable for this person having left. So as we continue to talk about potential home health care services, some of the things that are there are high technology pharmacy services. So some people go home on IV fluids, and the pharmacy actually sends their IV fluids and tubings and everything to their home, or they may get chemotherapy with a chemotherapy certified nurse at home. They may have skilled professional or paraprofessional services. Some of the things that, and going along with that are also the custodial services. So if you remember, we asked a question about what does a home health nurse do? Well, a home health nurse coordinates care, but she does not do the custodial services around the house. A paraprofessional is going to do that. So maybe the person needs help with activities of daily living like showering or bathing or help brushing their teeth or things like that. And so an RN is not going to go in to help them do those activities. A nurse's aide is going to go in to help them do those activities. There may be home medical services involved where physicians or nurse practitioners or physician assistants go in to examine the patient because it's too difficult for that patient to get to the doctor's office. We may have community support services coming in as well. And sometimes the community support services may be providing like custodial services where they're helping them clean their house or they're providing yard care for them because they aren't capable of doing that. The phases of a home visit starts with the pre-entry phase. And this is when the referral nurse collects the patient data and the nurse reviews the data and schedules a visit. And the nurse evaluates safety issues as well. So when we're talking about this phase, this is the phone call before somebody ever goes to the house. And so the nurse has to make sure, first of all, that they're going to get paid. If your insurance isn't going to pay for their home visits, chances are they're not going to come. And the nurse reviews the data and they schedule this visit when we're going to go into the entry phase. The nurse also evaluates the environment of where this person lives. It may not be safe for this nurse to go alone into this community. Or they may even need to take a police officer with them to that community because it is so unsafe for the nurse to go by themselves. And I've talked to some of the home health nurses in the past where they've gone into a home and literally there were drug paraphernalia around the living room, and here was the grandfather sitting across the room. And the grandfather wasn't doing the drugs, but drug activity was happening in that environment, and it wasn't safe. And it wasn't safe for the grandfather, it wasn't safe for the nurse to be there by themselves. In the entry phase, the nurse identifies needs and determines interventions. This is when the nurse actually goes to the house and evaluates the home. So they may be evaluating for, is the lighting good enough to keep you from having falls? Do you have too many throw rugs around and you're going to trip and fall and you just had hip surgery? They may identify that there's been oxygen delivered, but it's not secured well to the wall, and so we need to find a way to take care of that. And the nurses teaches the patient and the caregivers how to do the interventions that need to be performed. The nurse then documents any care that's given while they're at the home. Again, if you don't document it, it hasn't been done. The patient documentation following the patient visit and home care is the patient's condition, the skill care that has been provided, the patient's response to that care, the patient's progress towards discharge from home care, and an ongoing plan for continued care if they're going to be having home care for a long period of time, and also their plan for the next visit. Next time we're going to look at addressing these needs. And that's the end of this chapter. I'm noticing that this particular PowerPoint has some weird little, not typos, but formatting issues where letters ended up on the next line. So hopefully that isn't too distracting to you as you're looking at this, but we'll definitely examine some of these concepts more as we're talking about the nursing diagnoses and the nursing process. Bye.